that we have a technical word and we have a patient-friendly word. So I primarily worked in pressure ulcers. I might talk about an ischial pressure ulcer or a trochanteric pressure ulcer. I wouldn't use those words to describe it to a patient. Firstly, I would do a visual. I would say, here, you're at risk here, because that's where the bone's close to the surface. And I would say to the patient, what do you call that? Because some people will say thigh, some people will say hip, some people will say top of leg. It doesn't matter that they don't know the word trochanter. What they need to know is where the area of risk is. So we're focusing on lower limb today, and what I really want to do is to get you to think about what you do know already about anatomy. So we're going to start with a test of your anatomy knowledge. Now I've got 6 different diagrams and they are of differing levels of complexity. This is not a test because I will preempt it by saying I couldn't label some of these diagrams. And in some ways I am setting you up to fail because I don't expect that you can label these diagrams. But what I would like to do is get you to think about what you do and don't know, and whether that's relevant. So I'm going to hand them out. When you get them, label what you can, and then we're going to pass them along. So if you can't manage to label them, so do you want to share? Yes. And nobody will know what you did or did not label, okay? So just do what you can on that diagram that you have got. So you've all got a different structure within the casing of the lower leg. Some of you have got very simple diagrams to label. Some of you have got very complex diagrams. If you don't know what any of the lines link to, tell me what else you can say about it. They're all lower leg. There's a good start for you. Do you know the name of the bone? Do you know if it's an anterior view or a posterior view? Which is the lateral view? Which is the medial view? What can you say about that? If you don't know the technical name, what would you call it when you were describing it to a patient? And there are no points and nobody wins anything. This is just to see where we are. And it's going to be quite a quick fire round. So if you haven't labelled anything, don't worry. So Maria, can you pass to Joe? Joe, can you pass to Emily? Emily, I'm going to go here. Don't worry, just pass it along. So, quick change of brain. You're labelling a different system now. Or maybe slightly the same system, but a different bit of the anatomy. If somebody's labelled something and you think, oh, I don't think that's right, you can put your word as well. Because people are very keen to please, so they'll label something rather than nothing. And I'm really optimistic that we're going to get the skin completely right. Not looking at anybody when we're doing this. And I love looking at people's faces and the way that they're tapping bits of their own body thinking, I know the word for this, I know the word for this. So think about where you might have heard the word used generally. You know, what's the most common injury a footballer gets in their foot? How often do they fracture their metatarsals? Have you heard about somebody having an ACL tear? Anterior cruciate ligament tear. You've heard these, haven't you? Yeah? Which muscles have people ever pulled that you know? Which bones have they broken? Is your tibia in front of your fibula or your fibula in front of your tibia? If you've broken one of those bones, do you know? Is there anything in your bandaging teaching that might help you work out which one sits at the front?
In proper words.
Right, pass along. So if I take your one to give to Maria, you go that way. How have you got to? Oh, yeah, that's your new one. Right, so we're a little bit short on time because the moving round takes a minute. So literally have 30 seconds. Do what you can. Anything? Right. Last pass around and then we're going to stop. So pass this way. And I'll give it back to the front. How are you finding this? Is anybody finding it quite stressful?
That's what I was thinking. What a good idea.
Is it stressful?
Yes.
Are you looking at what people before you think about anything new? Thinking, damn, they labelled the one that I knew. I knew that one.
Honestly, I can't think when I'm put under pressure. Not like that.
That's absolutely fine. Okay, so can I ask you to do a really simple thing? Can I ask you to write pink on top of it? So I know this is the pink group. Everybody can do that. So how was that?
It's quite hard doing under pressure. Yeah.
Okay. Was it fun? Or was it not fun?
It was not fun.
Was not fun.
I think it's good because it makes you realise what you don't know.
Okay. Do you think any of that helps you in your daily practice? So just pass them back in. So thinking about when you're faced with a patient, how often do you sit there thinking, oh yeah, I must know where the perineal nerve is, and actually that's probably why this patient's got foot drop, or do those kind of thoughts pass through your head? Yes, sometimes. But I think I don't want to.
Not the exact words.
Yes, but you're trying to work out what's going wrong, aren't you? Yeah. So in your head, you're thinking, okay, what is it? Is it something I've done? Is it something about this patient's past medical history? Something about the current medical history? Is it something about a medication? Why have they got this symptom? Why am I seeing this sign? What is it that is happening in front of me? So this is all right. This is just for you to keep. You are not handing this in. So you can write on it. No, you can write on it. Okay. I'm hoping everybody learns something. And I want you to write a thing that you learned. So let's think about it a little bit more structurally. So just for your own peace of mind, let's have a look at the answers. So do you feel you got some of those correct? I've not looked at them. I'm not marking them. Does that look familiar to you? Are those the labels you hope that you wrote? And I would hope, given this is a leg circumference, you were quite good at the vessels in the lower leg, because we feel for the pulses, we should know what we are looking at. What about the bones? Was that much trickier? Did you kind of not sure which bone you're looking at? In reality, how many of these terms do you describe? I would expect you to know where your malleolus was, the difference between your lateral and medial malleolus. I would not, for example, expect you to know where your cilial line was. I don't even know if I'm saying that word correctly, because I don't know what the relevance is to what we do. Probably really important if you're an orthopaedic surgeon, but for us, what difference does that make? And I'd guess our podiatry colleagues would be much better at the bones of the foot than we are, but we know some of them because we hear them used quite commonly. Muscles we talk about a lot, don't we, in lower limb care? We talk about the importance of the muscle pump, the calf muscle pump, the foot muscle pump, keeping those muscles working, that patients don't get deconditions, they don't use muscle tone or muscle bulk, because that helps with the venous return. So we should know a little bit about the muscles, where they go, how they work. And I mentioned the importance of the nerves, and those kind of signs and symptoms you might be picking up. Is the patient reporting or not reporting pain? So if a patient's got diabetes and they're neuropathic, you might be much more careful about your bandaging, because if you or I had a bandage on and our toes were going a bit tingly and numb, we'd say something, but a patient with diabetes might not. If you're applying a bandage and it's trapping a nerve, the patient might say to you, I've got pins and needles. And do you think, well, pins and needles, is that nerve damage? Is that pressure damage? What is it that person is telling me about? And then the ligaments. And the ligaments are kind of this thing that, ligaments are a bit of a mystery, aren't they? People know what muscles are, and we see tendons. Have you all seen a tendon in a wound? And we teach students, be careful of the tendon. If you see a tendon, don't damage the tendon. Don't let the tendon dry out. Keep the tendon hydrated. Make sure you don't damage the tendon, because the person will get complete foot drop. But ligaments seem to be less well understood, and they join bones to bones. So if you lose tone in your ligaments, then you can have lots of problems. So I want to make anatomy a bit more real for you now, and think about what you're seeing, why it matters, what that link might be. And after each video, think about what you learned from it.
Like, so if you look at the skin, okay, it looks quite thick with the fat, but if you remove the fat off, this is actually skin. This fat is subcutaneous, meaning below the skin fat. And you can see that lovely white derm is there, okay? And no matter what skin color someone is here, the undersurface, that dermis, is always white and shiny, okay?
So do you remember that? The colour of your skin is in the epidermis, the outer surface of the skin. If If you peel that off, the skin underneath is the same colour. The dermis, it looks quite white there. It's obvious if it's vascularised, it'll be a bit pinker. There's no blood supply in that because it's a cadaver. Anything else you know about the skin?
How many, like, we know all the different layers that are in the skin.
Yeah.
How,
Thin it is.
yeah.
Isn't that a shock? That diagram I gave you, it makes this look like your skin's chunky and that your epidermis and your dermis are quite thick. I didn't put blood vessels on there. Epidermis has no blood vessels. It's just dead cells rising up through the top. The basal layer of the epidermis is able to create some new cells because of its intimate contact, it can take a little bit of oxygenation and nutrition.
Okay. This tiny thin thing here has all those components in cross section. Okay, so that's important for you to understand. Next,
The thickness on the leg of skin and fat.
Now, in this fat, whenever you're cutting through, you may encounter things like this. This is a vessel, this is a vein, and this is actually part of the great saphenous vein. Is that right, Charlotte? Yeah, okay. Charlotte's dissected that out. And if you, the importance of knowing that that vein and other veins lie in the fat is that if you're dissecting, or rather if you're debriding a wound in your setting, then, and you come into normal tissue, you can cut that and they can bleed. All right. If you have a vein just at the tip, don't go and wrap it up and put a tourniquet, just press on it for a while. Okay. And if it doesn't stop in 3 to 5 minutes, then wrap it up again, and you may need help from a hospital or a doctor. Now, we've gone through skin and we've gone through fat, and we looked at a nice little vein here. All right. The important structure, the most important structure that I want to impress upon anyone who's doing debridement, this structure, this white structure, is fascia.
Do you all recognise that? Think about when you buy a joint of meat. You know when it gets that thick fibrous white thing over the top of it? That's what you're seeing here.
And you can see that there is a structure. There's your muscle deep there, and there's something there. Okay, and that's the fascia. So we're going to cut this fascia. Charlotte, can see the muscle popping out. Okay, so we've had skin, we have fat, and underneath that we have fascia, this structure here, and you can see it's quite a significant structure when you look at it like that. And underneath that, that stuff is muscle. Okay, that stuff is muscle. This white stuff underneath that muscle, that is tendon.
So when you label a diagram of the skin, did you manage to label the fascia? It's often not represented, but we have fascia all across our body. It holds everything in place, and particularly when it comes to the muscles, it holds them within a rigid structure. So when we talk about the calf muscle pump, the calf muscle pushes the blood supply back up. What stops the calf muscle just keep bulging and bulging and bulging? The fascia. And so the way it's got the compression in the middle is because it can't go any further, because it's got a rigid structure outside of it. So if you think about, you may have heard in your clinical history of patients having something like a fasciotomy. So they've had some lower limb surgery, they've got inflammation in the muscle, that muscle is swelling and swelling and swelling, it's got nowhere to go. They have to cut the fascia to relieve that swelling, or otherwise that muscle will die because of the tension the muscle's placing on the vessels that lie within that muscle. So the fascia is a really important thing in terms of calf muscle pump, but we don't necessarily recognise it or talk about what it does.
To demonstrate, the first thing is, look at that. It's a lovely representation of a vein within the fat. Now these are one of the superficial veins. So this is a short saphenous vein. Now the other system is a deep system, and you can see an example of a vein here, and these veins go within the muscle. Okay, and they're part of the deep venous system. The importance of the deep venous system is that if the blood in the deep venous system isn't going up, you can get deep vein thrombosis, a DVT. So that's the importance of that. Okay, the importance of superficial system is, of course, it's draining quite a lot of blood. And clinically, is these are the veins that give you visible varicose veins. So when you see people with varicosities of the veins, is because the valves in the veins are incompetent, and then they sort of balloon out and they're visible. Of course, that you can have the same valvular incompetence in the deep veins as well. So, but what I want to show you is the muscles, remember those nice muscles that we saw sort of contracting and relaxing. Obviously in a cadaveric specimen we can't show active contraction and relaxation, but we can show you what happens. So that's the gastrocnemius muscle here. The muscle,
did you label those?
Is a big muscle, it's called the soleus, and you've got other muscles in there, and you can see how you've got a vein sort of running in there. And so let's see what happens when we extend and flex the ankle. Can you see how the muscle is moving? You have to understand that this is somewhat artificial, in as much as in real life all of this will be tightly kept together by your friend the fascia, which remember you don't go deep to, because deep to it is all this kit, right? But it's an interesting thing showing you what happens there. Now in real life your muscle here will actually contract, which I can't make it do, but imagine in muscle contracts it pulls, and you can see how the foot is then moving. So as it contracts it gets short, the foot is moving, and as relaxes it allows the foot to straighten out. Now these veins that we have seen, we have the short saphenous as one of the superficial, we have the deep thing, they now travel proximally past the knee, okay, and go up. Now when we come up to the groin area, upper thigh area, right, remember if you've seen our other video, that's the great saphenous vein or the long saphenous vein, which runs on the medial side of the leg and comes up. Okay, and of course the short saphenous veins drains into a deeper vein in the knee, but all of these superficial things now will come and drain into the femoral vein. So the femoral vein is the big daddy of the deep vein. So all of the veins, the superficial and the deep, will end up in draining, and you can see that that's happening right there, where they're all draining into that, and then the blood will go up in through the pelvis, in through the abdomen, up through the chest wall into the heart.
So big vessel there you're dealing with, but also remember what he said about the vessels in the lower leg all draining up behind the knee in that very tight space up to the thigh. And whether you're thinking about drainage of venous blood or drainage of lymphatic fluid, you can influence what's going on in the lower limb by doing some massage, some manual drainage around the groin sometimes. Always explain to the patient before you start massaging the upper leg so that they understand that what you're trying to do. So if the lower limb is painful, you can influence that flow a little bit from higher up.
So the first thing is, you know how you feel for the pulse on the top of the foot, sort of around.
So you're all
here.
familiar with
That's
this
the
diagram?
dorsalis pedis pulse, and that dorsalis pedis artery actually comes from the anterior tibial artery, which starts a bit higher. So this one, the guys have also dissected, oh, that's your anterior tibial artery, and you can see that it's going there. And if I can get a skin hook here, Charlotte, please, thank you. Okay, and you can see how it's going all the way down there, and there it is running and going deeper and going to supply the foot.
See next to it, very close to it here, we've got the tendon. We're thinking about sometimes when you can't palpate the vessel, if you can move the toe, you'll feel the tendon move. If you know where the tendon is, you can go next to the tendon, might help you find the vessel.
Okay, that's the posterior tibial artery, which a lot of you, may feel in practice when you're checking for pulses. And here's your anatomy showing you where things are. This is the medial malleolus. Remember, you feel for that. And look, just behind it is your posterior tibial artery. And if this was an alive patient, then you'd get pulsations there. At this point, it would be a good idea for you guys to put your finger behind your own medial malleolus and feel for it. You see how it lies just behind it. So when you're feeling for it, you got to put your finger, and if you put it like this, you'll push it away. So you got to put your finger and press it against the bone so that it has nowhere to run away from you, and you can feel the pulsations. Okay, and that goes all the way into the sole of the foot.
So again, a little hint there, that's really useful, isn't it? How many times have you thought you found that vessel and then you lose it because you're pressing it downwards? But again, you saw the tendon running alongside it. If you get the person to move the foot, help you locate it, push upwards and push it against that medial malleolus, might give you a better pulse.
The tendons is big white structure here, okay, and you can see it's essentially the tendon.
You see that's the vessel just tied off there, so it's in the same spot.
Onto the bone. So tendon, so you can see again what a tendon looks like, and remember what I said, muscle, the tendon comes off the muscle, and imagine that the muscle is contracting here. If it contracts, it then moves whatever structure is attached to, in this case, the big toe.
So that was when we were looking at the anterior tibial or the dorsalis pedis pulse. And if you can feel the dorsalis pedis, don't worry too much about the anterior tibial. If you can feel the anterior tibial, it's the same vessel as the dorsalis pedis. So if you run your hand along that tendon, get them to move the foot till you find the tendon, you should be able to find that vessel. So we're moving up a little bit now.
These muscles here are the gluteus maximus. You can see the fibers, and they're coming from the buttock here. And lying deep to that is the sciatic nerve, but right on the inferior edge, on the bottom edge, the nerve will pop out, and Matt and Charlotte have got this nerve for us. And look at the size of that. That's my little finger in comparison.
Nice.
And to make even further comparison, remember we looked at the posterior tibial nerve going onto the ankle? That's the size of the posterior tibial nerve.
Is that bigger than you thought for your sciatic nerve?
Yeah. You say you've got
And this is the
back
common
nerve.
peroneal nerve here.
Just
Okay,
coming
it
down.
comes from the back of the leg, but then it will go and curl around the fibular bone. And this is the fibular bone here. The importance of the anatomy here is that if you've got a bandage that comes up too high or is too tight, then it will squash the nerve, and because there's bone behind it, it's squashed between your tight bandage and your fibular bone.
So again, a reminder there, look how little skin there is, and look where that nerve crosses right over the bone, directly over the bone. So if you tie your bandage off over that, the risk of the patient saying, it's painful, I've got pins and needles, my foot's going numb, and if you don't relieve that, the patient will get foot drop. So there's a real clinical need to understand why that link is there. Just popping back up to that sciatic nerve, were you all surprised at how big it was? The other thing that Mr. M didn't mention, but hopefully you could work it from the anatomy, is how close it is to that point of your pelvis. So when patients with pressure ulcers say, I've got numbness, think about how they sat, think about how they trapped that sciatic nerve. Have they lost some muscle mass? Is that causing them a problem? And this is the final video.
Inserting. So what we're going to show you is the fat pad that is in the heel. We're going to show you where the calcaneus bone is, where it's a common area for pressure sores in patients who are laid down. And finally, I'm going to make a little incision and show you where the Achilles tendon is inserting onto that. And you can see the little septae, and it creates...
You said septae, do you know what a septae is?
Little pockets of fat. Okay, as you're saying, you can see how thick all this fat is in the heel. There's your calcaneus, but is that just a bit superior to that is your Achilles tendon. And the Achilles tendon is that really, really big tendon, like the sciatic nerve was the biggest nerve. The Achilles tendon is the biggest.
Look how thin that skin is close to the tendon though.
Calcaneum right there. So you can see the distance between here and here is very little. So if somebody's been laid and gets a pressure sore area, this is very much in the vicinity, and you can not only get involvement but destruction of the Achilles tendon. So that's quite important. And of course, if you're debriding in this area, it's quite easy, if you're not careful, to injure that. Okay, and if you injure that, that's a big problem. That's a big functional issue there. Okay, so I think this demonstrates quite nicely how thin your skin is, how susceptible all that skin is to pressure, because this thin skin is being pushed against bone, so it causes a pressure source to occur, while your heel itself, or the plantar aspect of your heel, is very well padded.
So first of all, had you heard of septae before? I hadn't until we did this video. And it's impressive how much fat is under your heel, isn't it? Under your heel, where you stand. And if you think that's logical, because it needs to take your body weight, and it might need to take you running or putting a lot of weight through that area. And the septae you mentioned are collagen bundles. So in your abdomen, in your buttocks, your collagen, your fat you can displace. But you don't want that happening under your calcaneus. You want it to cause buffering. So those septae help retain the fat, a bit like bubble wrap, into little bubbles where it's meant to be. And Mr. M talked about the lack of padding and the risk on pressure ulcers around that area of the body. But actually think about that in terms of lower limb. So when we're talking to patients about how they can assist in healing their wounds or prevention of further wounds, we say to them, you need to improve your calf muscle tone, you need to mobilise, but if you're seated, can you elevate your legs, don't we? And how many patients do you see who put their heels on a footstool? What's the risk there? Or think about when you're bandaging. You know, when you bandage, when you do that and close the heel, around the front and close the heel. If you don't protect that heel, what's the risk of damage at that point, and what's the structure underlying that you are risking damaging? So it really should impress on you the lack of tissue we have to protect our skin from our bones. And hopefully just looking at those has really made you think not just about leg ulcers, but also pressure ulcers, about things like skin tears, how easy it would be if you take that superficial skin off, the kind of damage that you're going to cause there. So, what did you learn? Loads?
Yeah. It was like having kind of come out the other end now, being retired, having practiced for all these years, finally meeting things face to face that you've talked about, you know, the different muscles, the different vessels, looking at, like you say, about your tendons, not letting them dry out, all those things. And you just think, if I'd have had that at the start, it would have made everything else I've known all these years.
Was it helpful, like the little hints and tips about, oh, this vessel's here, and if you push it this way, or this nerve's here?
Like where to tie your bandage off, or where to finish your bandage off.
So, does it give you a little bit of hope for anatomy, that if we teach anatomy properly, if we link it to clinical practice, or even to a particular specialty, so all that labelling I made you do at the beginning, are you ever going to use the names of those bits of a bone? But actually it might be quite useful to know a bit more about the muscles and the tendons, because now you can start to think, oh, actually that video that Jacqui showed me, there's not much coverage there, or oh, the malleolus, oh, where do I feel for this, or if I move the foot in this way, if I rotate the foot, flex the foot, can I now feel a tendon? There was a vessel next to that tendon, wasn't there?
Yeah.
And we've always taught it, if you can't find a vessel, just flex the foot, you know, dorsiflex, plantarflex, what can you feel? But maybe not realising what you're telling people, whereas actually, if instead of going, right, today we're going to learn blood vessels, tomorrow we're going to learn muscles, if we put the whole of the lower limb together, we can start to think, what does that mean? We can start to think not just how it might influence what we do, but it might influence how we listen to what a patient's telling us about a particular symptom that they've got.
It brings a whole new meaning to me for that, you know, seeing is believing.
Yeah.
So,
And I think clinicians are quite visual learners, aren't they? And it would be so much better if we could do it with a live person and you could see the vessels back, but you can't, you know, you obviously can't do that ethically. It's not, nobody would be prepared to do that. But just seeing that, how close all those structures are, I think really helps you to think about what you're asking from a patient, why things may or may not heal, what the structures are that are involved that you might not even have thought about before. So hopefully you found it useful. Hopefully it hasn't put you off your lunch. Hopefully you've made some notes on what you found was helpful. So enjoy your lunch.
Thank you.